just like to take this opportunity to present some data from a study we did, and looking at the effects of antibiotic resistance in patient management. Okay, just briefly, Mycoplasma genitalium is known as an L form, or a bacteria that has no cell wall. Up in the corner we can see a picture of the Mycoplasma genitalium organism, and at the end you can see have we got a laser pointer? Oops. We can see a wee attachment site that's important for its binding to cells. It's known as an intracellular parasite, so it enters the cell, target cell, and because it has a very small genome, it doesn't have enough ability to produce a lot of its own amino acids, so it derives that from the cell that it binds to. One of the interesting things about this organism is that it was used as a model to create the first synthetic organism based on its genome in 2008. The clinical presentation, since molecular tests have been used more commonly, we find that association with various diseases, including second most common cause of NGU in males, and its role in female disease is probably less defined, but definitely there is some association there, and it still remains whether it's got a role in terms of infertility. Okay, testing at Canterbury Health Laboratories, we started a real-time PCR for its detection back in 2010, and we've been offering a service, but over the years we've seen a steady increase in demand for the test, and the orange represents how many positives we've had per sample tested, and the rate is staying proportional, about 12%, and this is of significance because we changed from an in-house testing in 2016 to a commercial assay, and we still see the same ratios. Okay, so is there an emerging problem? We're talking to people from the local sexual health clinic, mainly Edward. They have seen sort of treatment failures. The recommended antibiotic for treatment of Mycoplasma genitalium is a macrolide, and one of the good examples is azithromycin. And that's always been quite a popular antibiotic to use because it can be given in 1 gram dose, so you can directly observe the patient taking their treatment before they leave the clinic. But international and local data is showing there's increasing incidence of treatment failures, and there's a group in Australia that's been very, very good at adopting and analysing what's happening, and they've shown that macrolide efficacy, so you need a 95% efficacy of the antibiotic to be used as an empirical treatment. They've shown rates have dropped down to 50 to 70%. Back in 2009, we decided to do a study and just look at these patients that had failed treatment. And we found 50 males with NGU and tested them and found that 11 of them had Mycoplasma genitalium, of which 9 of them had antibiotic resistance, mainly to azithromycin. So this made us think more along the lines, how common is this antibiotic resistance, and are we going to start seeing more treatment failures? An Australian group also produced, just after that publication, they put out a publication about if you have treat with azithromycin and you fail, the secondary drug to use is a fluoroquinolone called moxifloxacin. And they started showing that they're seeing treatment failures using moxifloxacin. So there's definitely an emerging problem with selective pressure using broad-spectrum antibiotics. So our study was kindly supported by CMRF grant and Canterbury Health, the CDHB. We wanted to look at samples that were submitted to the laboratory and look for fluoroquinolone and macrolide resistance. The samples were screened with a real-time PCR targeting the attachment gene for Mycoplasma genitalium. Macrolide resistance was detected by mutation in the 23S ribosomal RNA. This macrolides inhibit Mycoplasma genitalium by inhibiting protein synthesis. So the ribosomal genes are important for that resistance. Also, looking at the fluoroquinolone resistance, there's fluoroquinolones like moxifloxacin inhibit Mycoplasma genitalium DNA replication, so they're very effective drugs. But there's two type of enzymes with 4 genes, they called gyrase and topoisomerase, that are very important in processing DNA. And these were done by mutation detection through DNA sequencing. Go to the next slide. Could it move? There we go. Okay, so 157 samples were collected that were positive. Due to the acceptance that it's definitely a cause of NGU in the males, most of the samples submitted were urine samples. Median age was 27, and we were able to get 115 of the samples with a PCR result and also a product for DNA sequencing. And it was surprisingly that we had such a high resistance rate when we looked at the macrolide resistance. It detected 73% of those 115 samples. I sort of mentioned that you need a 95% sensitivity rate to use a drug as an empiric treatment, so this has fallen well below those levels. So if you look at the main mutation, it's probably not too interesting for a lot of you, but we definitely see a predominant mutation. You know, DNA. But if we look at the sensitivity of if you have a 23S mutation versus using a test of cure, whether they clear the organism or not using the treatment, definitely if you have one of these 23S mutations, the negative predictive, positive predictive value is quite high, so you're definitely going to have some sort of phenotypic expression that you're going to get treatment failure. But if you don't have the mutation, it's pretty unlikely that the patient should fail treatment. Okay, just looking at some of the results from the topoisomerase mutation screening, looking for fluoroquinolone resistance, which is quite surprising. We thought we've had a couple of patients with treatment failure, but when we looked at the genetic results, there's actually quite a high rate of patients with samples that have a mutation that's associated with moxifloxacin resistance. So you're not only seeing your first line treatment resistance falling well below 50%, now you're starting to see your second line moxifloxacin fall below 80%. And that's a worrying, it's quite a worrying trend there, so. Again, it's just looking at the different mutations. People from the lab would be quite interested to know that one particular gene has most of the mutations, PAR-C, that's associated with the moxifloxacin resistance. So in terms of assay development and developing an assay to screen for these resistant markers, PAR-C is a very good target. Okay, so just summarising those results from the study, we see high rates of macrolide resistance. Now we're seeing significant levels of moxifloxacin resistance. We see isolates at macrolide resistant plus it's moxifloxacin sensitive. We have isolates that are macrolide susceptible but fluoroquinolone resistant, which I've not seen any other paper present this data yet. So you've already got isolates that are preloaded before you can think about your second line treatment that could be resistant to that drug. And also you've got patients that are resistant to both. And I'll just quickly go through a weak case study, just looking at one patient that was resistant to both antibiotics and the sort of journey they had through the health system. So as a male presented with a discharge, he was screened for gonorrhea and chlamydia trachomatis, which is the usual routine screens that happen first up. Initial treatment was amoxicillin, which is not a very effective drug if you've got a bacteria that has no cell wall. Subsequently, because it was negative, they had a reflex test, and we go into testing for Mycoplasma genitalium and trichomonas. Okay, so the first treatment started specific for the Mycoplasma genitalium was azithromycin, the extended course. In test to cure, the Mycoplasma genitalium was still detected. And subsequently, we tested that and we found a mutation that's associated with the resistance. Therefore, the treatment was changed to moxifloxacin. But we didn't have any tests at the time to detect if there was resistance mechanisms happening in this organism. So they were treated and then followed up, and they still presented asymptomatic. But the test to cure, there was still Mycoplasma genitalium detected. And subsequently, we found it had a 2-stage mutation, which gives high-level resistance. And so treatment was changed to pristinamycin plus the doxycycline, and then the test to cure became negative. And the duration of that patient's treatment from first presentation was 187 days. So you've got a patient that's potentially carrying resistant organisms and haven't been appropriately treated, and therefore can propagate the spread of these organisms. Okay, so just quickly, the main thing we probably would want to say is that we do need some sort of guidelines around treating patients, and very much the laboratory have got to play a key role in detecting these mutations before you start specific treatment. Just recently, in 2016, we changed to an assay, a commercial assay by SpeedX that includes not only Mycoplasma genitalium detection, but also the macrolide resistance detection in one tube. So that's it's giving you that antibiotic resistance data when we first do the test. And just some of the data from that, we're still finding mutation rates are up to 55%. Okay, so the conclusion is there is an increasing antibiotic resistance, and we do see a lot of treatment failures. We do need the laboratory to help guide your treatment, and we've got to preserve our limited resources in our antibiotics. Okay, and just like to thank the following people for their help. Cheers.